Welcome to the 24th Annual Astute Clinician Lecture. I'm Dr. Jim Gilman, Chief Executive Officer of the NIH Clinical Center. Today's special lecture is an NIH Director's Wednesday afternoon lecture series event hosted by the Clinical Center. Dr. Francis Collins, the NIH Director, is not able to join us today due to other commitments. The Astute Clinician Lectureship was established through a gift from the late Dr. Robert W. Miller and his wife, Haruko. It honors a U.S. scientist who has observed an unusual clinical occurrence and by investigating it has opened an important new avenue of research. Today, we welcome Dr. Brigitte Widemann, who will speak on advancing therapies for neurofibromatosis type 1, lessons learned from every patient. Dr. Widemann earned her medical degree from the University of Cologne in Germany and subsequently completed her pediatric residency. She then moved to the NIH for a pediatric hematology and oncology fellowship in the Pediatric Oncology Branch of the National Cancer Institute. Dr. Widemann is the chief of the National Cancer Institute's Pediatric Oncology Branch. She trained as a pediatric oncologist with expertise in drug development and early clinical trials for children with refractory cancers. She applied her expertise to study genetic tumor predisposition syndromes, in particular neurofibromatosis type 1, and very rare pediatric and adult solid tumors. These efforts resulted in the understanding of the natural history and biology of neurofibromatosis type 1 related tumors and other solid tumors, and then in the development of novel, meaningful trial endpoints and outcome measures. Based on the results of her clinical trials in 2020, the FDA approved the first medical therapy, the MEK inhibitor selumetinib, for children with inoperable and symptomatic plexiform neurofibromas. Dr. Widemann is also co-leading a Cancer Moonshot funded effort, which aims to accelerate the understanding of very rare pediatric and young adult solid tumors with unmet medical need and the development of therapeutic trials through a collaboration of patients, advocates, clinicians, extramural researchers, and other partners. She is an elected member of the Association of American Physicians and is a recipient of the 2021 AACR Joseph H. Burchinell Award for Outstanding Achievement in Clinical Cancer Research. And now, Dr. Widemann.
Thank you so much, Dr. Gilman, for this introduction. I am very humbled to be receiving this award and giving this lecture today in honor of Dr. Robert Miller, who, looking back at his achievements, was indeed an exceptional pediatrician, scientist, and epidemiologist. Thank you for giving me this honor today. I will talk about the journey to advancing therapies for neurofibromatosis type 1, or in short, NF1, and focus on lessons learned that we learned from every patient. I have no disclosures, but we'll talk about clinical trials with investigational agents. As Dr. Gilman alluded to, I came in 1992 to the NIH Clinical Center as a first-year fellow in the then pediatric branch under the leadership of Dr. Phil Pizzo to get rigorous training in pediatric oncology, which was then not available in Germany, where I had trained in Cologne and also in part at the University of Glasgow. What really attracted me was that I knew there was world-class basic and clinical research, but in particular, the closeness of the bench to the bedside and how this could lead to innovative treatments for patients with unmet need. After completing the first year, the clinical training year, I joined the Pharmacology and Experimental Therapeutics section, which was directed by Dr. Frank Baylis. But Dr. Peter Adamson was my direct mentor, and many of you know that he, after leaving the NCI, became the chair of the Children's Oncology Group. I learned a lot that prepared me for doing clinical trials in NF1 during this time. And I'm showing you here a review of early phase clinical trials that we conducted at the NCI between 1992 and 2005 for children with solid tumors. This is a review by Dr. Kim, who was a fellow in the branch as well. As you can see, during that time, we enrolled predominantly brain tumors, Ewing sarcoma, The review focused on phase 1 trials, and you can see that we were very effective in establishing the primary objective. 90% of the patients were evaluable for determination of the recommended phase 2 dose or maximum tolerated dose. And our rate of dose-limiting toxicities was fairly low with 17%. Only one patient had a drug-related or a possibly drug-related death, and this was a patient with a brain tumor. You also see that the complete or partial response rate was very low. And I want to point out, in phase 1 trials, this is not the primary objective, but it was sobering to see that the median overall survival from time of enrollment was only 5 months. Doing these clinical trials was not easy, and I want to thank Peter for teaching me how to be honest with patients while at the same time never giving up or taking hope away from them. It definitely prepared me for not being afraid of taking on a new disease. As pediatric oncologists, we were used to failure in the sense of drugs not working, and I was not afraid that this might be taking anything away from when we started work in NF1. NF1 really became my project and is what got me tenure at the NIH in 2009. It is a common single gene disorder and a prototype rasopathy, meaning resulting in activation of the RAS pathway. While characterized by cutaneous stigmata, such as cafe au lait macules, skin tumors, and axillary or inguinal freckling, very importantly, patients with NF1 develop a variety of tumors. And for today, I focus on Flexophone Neurofibromas, atypical neurofibromas, and malignant peripheral nerve sheath tumors. And very, very importantly, there was no effective medical therapy for these tumors, but there were many agents in development for cancers in adults that target the RAS pathway. And this is why we actually embarked on studying neurofibromatosis type 1. As you can see in the cartoon here, neurofibromin, the NF1 gene product, functions as a GTPase activating protein. That means it facilitates turning active GTP-bound RAS to inactive GDP-bound RAS. When neurofibromin is deficient through mutation, this results in activation of RAS pathways, including the RAG-RO pathway, the RAF, MEK, ERK pathway, and the PI3 kinase pathway. In the beginning of the 2000s and end of 2000, like around 1998, farnesyltransferase inhibitors were very much studied by pharmaceutical companies with the goal to block RAS farnesylation and with that RAS activity. And this was the first clinical trial that I took forward for patients with NF1. You can see that this was not successful in the sense that this resulted in activity for patients, because subsequently I and others evaluated a number of additional agents without really any substantial clinical success until we studied MEK inhibitors. And I'll take you through this journey today. When we began studying NF1, we knew that patients develop skin tumors. Almost everybody does, but these typically develop in adolescence or in early adulthood. These tumors never transform to become malignant tumors. The tumor that I was focused on was plexiform neurofibroma, which occur in younger patients and we believe are congenital. And these tumors, while histologically benign, cause a lot of morbidity, as I will show you. And we knew that these tumors transform up to 16% to malignant peripheral nerve sheath tumors, very aggressive cancers, where there's only one curative treatment option, complete surgery with wide negative margins. Through studying these tumors, we began to learn a lot more about a tumor called atypical neurofibroma, which is a precursor to malignant peripheral nerve sheath tumors. And I'll talk about this during the talk, and also about the genomic characteristics of these tumors that help us understand the malignant transformation better. When we started the work, we measured tumors, plexiform neurofibromas, using 1 or 2 dimensional measurements. At this point, we use for every patient on clinical trials volumetric measurements. When we started the work, we had no idea about the natural history of these tumors. Many of us thought these are erratically growing. We now have characterized the natural history. When we started, there were few clinical trials and no meaningful outcome measures. And now we have meaningful outcome measures and functional and patient-reported outcomes. And we have, for the first time, a medical therapy approved for these tumors. Atypical neurofibromas were not on our radar at all when we started NF1. We knew they were characterized by pathologic changes, but now we have characterized them as precursors for malignant peripheral nerve sheath tumors. We are and have initiated the first clinical trial targeting these tumors. And as it relates to malignant peripheral nerve sheath tumors, while we have no effective targeted therapy to date, we are working on a strategy to prevent these tumors through surgical resection of atypical neurofibromas. Finally, over the years, preclinical models have been developed for all three tumors, and I can say that the model for Flexophone Neurofibromas is validated, which is a huge advance. I'm starting now with Flexophone Neurofibromas and lead you through how we went about studying these tumors. We knew they are developing in very young patients, and we knew, as you can see here, that they can cause disfigurement and grow quite quickly in young patients, and that these tumors are very bright on MRI Spore sequences compared to the surrounding tissue. One aspect that was incredibly difficult was to measure change in the size of these tumors. And that's something that we have to do in clinical trials, at least we do in oncology clinical trials. And I'm showing this here to you in a pelvic plexiform neurofibroma. You see this bright area, that is the tumor in a patient in 2007. You see it in 2008, you see it in 2009, and in 2012. And while I do think you can see there has been some increase over time, most of the radiology reports would tell us there's no change, because we usually look back for maximum a few months, but not for a year. These tumors grow much more slowly over time compared to cancer tumors. So Dr. Jeffrey Solomon developed a method for us using biometric MRI analysis, where every slice containing tumor is captured with the area, and we can calculate the tumor volume. And Dr. Eva Dombey then subsequently used this method in the natural history studies that we conducted and in clinical trials. And this was a very, very critical step to making progress in NF1 tumors. You can now see that within a year, the tumor had an increase in volume of 28%, and that by the time there were 5 or 6 years, the tumor volume had more than doubled. And our approach was to use this more sensitive and reproducible method in parallel in a natural history study, but at the same time, we didn't want to wait with clinical trials evaluating the potential benefit of novel agents. And the progression was defined by a 20% increase in volume and a response same by a 20% decrease in volume. Dr. Dombey has conducted central response evaluation on many national multi-site clinical trials. This is another quick example to just show you how much better the volumetric method is. You see again a patient with a neck plexiform neurofibroma, and you can see by line measurements, the increase is only 14%, which would not qualify as progression, but by volumetric measurement, the tumor has very substantially increased, and you can see it on the plot on the left side. With this, we started embarking on natural history studies, and I don't have to tell you that the NIH Clinical Center is the place to conduct natural history studies. The first person that I really learned from a lot is Dr. Bruce Korf, a geneticist and neurologist who actually started the first natural history study in 2001, and we participated in it. This study also used over 3 years volumetric analysis, and we now, in addition to our natural history study, which we started in 2008, have volumetric measurements in kids for over 20 years. That's a huge treasure. Our study focused on understanding comprehensively and longitudinally plexiform neurofibromas and MPNSTs. We didn't even think at the beginning of atypical neurofibromas. And then we were very fortunate to have many investigators at the NIH and at the Clinical Center helping us understand other aspects of NF1, such as social emotional function, motor function, hearing, and endocrine manifestations. a very esteemed colleague of mine, after we were a few years into the natural history study, said, Brigitte, when are you going to stop? This is a very research-intensive study. And I think it's a very relevant question because we want to always think about when can we stop and when can we start and embark on something new. However, we did not stop with the natural history study, and I think that was a good decision. More than 25 manuscripts have come out of this, and some of them were very important, and I want to just highlight a few of them. Our characterization of the Flexophone Neurofibroma growth on the natural history study served as the control group for our subsequent submission to the FDA and was critical to FDA approval. The use of whole body MRI and of characterizing the tumors carefully led to identification of the precursor lesion to malignant peripheral nerve sheath tumors. Dr. Pam Walters and Stacy Martin have used natural history data in our patients for the validation of a pain scale that we can hopefully use in future clinical trials as a primary endpoint. And the natural history study has helped us in the genomic characterization of these tumors. Shown here are the key findings from the natural history study for the growth of Flexophone Neurofibromas. The plot on the right-hand side shows you that children, young children, have by far the most rapidly growing tumors, which is why we were so interested in focusing our drug development efforts on young children and not on the adults where we don't see tumors growing. Dr. Gross did an analysis of the morbidity that comes from these tumors, and she could show that most of the patients at the first time they came to the NIH Clinical Center had already substantial morbidity. And once it was present, it did not reverse. The first clinical trial that we conducted in parallel to the natural history study was a phase 2 trial of tipifarnib. And I want to say this was one of the most important studies done to date in NF1. It happened at a time when there were no agents really studied. And so we actually embarked on a double-blinded, placebo-controlled, flexible crossover design. And Dr. Frank Baylis really gets the credit for the design of this study, which taught us a lot. Again, a very esteemed colleague who I'm very friendly with even today said, Brigitte, is there a stopping route to your trial? Because this investigator did anticipate that tipifarnib, the farnesyltransferase inhibitor, was not going to work. And he was right. You can see here the Kaplan-Meier curves for tipifarnib or for the placebo, independent of whether the patient started on the first or the second phase, and they pretty much are overlay. However, what this study taught us, for the first time, we had natural history data on the progression of plexiform neurofibromas, which we could use as benchmarks for future clinical trials. And we could clearly demonstrate that the use of volumetric MRI analysis compared to two-dimensional or one-dimensional measurements was really the only method how we could, within a reasonable time period, complete these studies. The reason why tipifarnib did not work is that tumors can undergo a different mechanism of activation. When we block farnesylation, the RAS can be germinylation, and this then allows RAS to insert into the plasma membrane. So clearly tipifarnib was not effective for these tumors. Another thing that we observed in these patients on the tipifarnib study was that tumors grow faster in kids, as you can see here, a 3-year-old, and then on the further down, a 21-year-old. An observation that the natural history study then also showed. And this is why we were surprised when, if you look at the lower panel, we enrolled a patient, a 14-year-old, and this patient had a nodular lesion that clearly grew, and already 6 months after being on study, he came off the treatment phase for progressive disease. This was actually the first time that we identified a distinct nodular lesion. At that time, we didn't know that this was a malignant precursor lesion. However, after this patient was removed from the study and underwent a biopsy, this was a low-grade MPNST and was treated with surgical resection. This patient later on developed a high-grade MPNST and unfortunately died from the disease. With the benchmark study of the tipifarnib study and the placebo data, we conducted a number of clinical trials in patients with progressively growing plexiform neurofibromas to see if we could improve the progression-free survival. And you can see here that pirfenidone, an antifibrotic agent, had no effect. Sirolimus, an mTOR inhibitor, shifted the curve ever so slightly. PEG interferon alpha-2b did result in a doubling of the time to progression and certainly had some activity. However, only 2 out of 175 patients had a confirmed partial response, and those were both on the PEG Intron trial. This was pretty sobering and brings me back to the days when we did phase 1 clinical trials in patients with refractory cancers, with the difference that patients with NF1 tend to survive for many, many years. And this is shown here in a young boy. He was 3 years old when we saw him for the first time with a neck and chest plexiform neurofibroma, who was enrolled in a number of our clinical trials, including the PEG interferon trial. By the time he was 14 years old, his tumor had more than tripled. He was on multiple pain medications. He had undergone multiple surgeries, and he had developed bowel incontinence. So we clearly had to make some progress in these tumors. And I was anxiously waiting to see if we would actually make progress in plexiform neurofibromas. We then conducted our phase 1 trial of the MEK inhibitor selumetinib. We did this without preclinical data because when we started this study, there were no preclinical models. To my greatest surprise, and also I was thrilled, we saw in every single patient some volumetric reduction in their tumors, clearly showing that this pathway is important for plexiform neurofibromas. 17 out of 24 patients on this phase 1 study had a partial response, and the responses were observed at 60% of the adult recommended dose. Prior to starting this study, it was almost impossible to get a pharmaceutical partner to agree to do this study because we wanted to treat children, and MEK inhibitors had not been evaluated in children, and our children did not have a malignant disease. I want to thank Austin Doyle at CTEP for really allowing us to start and do this trial. Without the support from CTEP, I don't know that we would have an approved agent at this point in time. On the clinical phase 1 trial, we also observed anecdotal benefit, and you can see this clearly in the patient here with a large pelvic luteal plexiform neurofibroma that was progressively growing and demonstrated shrinkage on selumetinib. When we approached the FDA to see if we could get breakthrough therapy designation, the FDA told us, no, you have not looked at this prospectively and you kind of lost this opportunity. You should have included patient-reported outcomes or something to measure the clinical benefit in your phase 1 clinical trial. And this is an important lesson for anybody doing rare tumors research. If you have something where you anticipate that it might be working, even in early trials such as phase 1 trials, incorporating measures that look at patient clinical benefit, I think is a very good idea. We went back to the drawing board and developed a multi-site phase 2 registration trial of selumetinib for children with symptomatic plexiform neurofibromas. The primary objective was the overall response rate, but we incorporated a host of functional and patient-reported outcome measures to see if in these patients with symptomatic tumors, we could measure clinical benefit. You can see that the waterfall plot of response mirrors that from the phase 1 study. 34 of 50 patients had a confirmed partial response, but we were also in this study able to demonstrate benefit with improvement in pain and function. Here you see an improvement in disfigurement in a patient with a neck tumor. And then here, where Drs. Walters and Martin looked at global impression of change in tumor-related morbidities, parent-reported and child-reported global impression of change showed overwhelmingly an improvement, and very few patients reported any worsening. Drs. Walters and Martin also looked at the NRS-11, that's the pain scale from 0 to 10 in our patients, and could show an overall decrease in tumor pain intensity over treatment cycles, and one cycle is 4 weeks. And they could show that from baseline to pre-cycle 12, which is approximately 1 year, there was an average decrease in pain points by 2 or more, which is clinically significant and not just statistically significant. This data was really important for the FDA approval, and I cannot thank our team there, Pam and Stacy, enough for really the hard work they have done for this clinical trial. We also presented individual cases of improvement for every patient to the FDA. And I want to show you an example here of a patient with a neck Flexophone Neurofibroma on axial MRI who came and was enrolled at the Children's Hospital of Philadelphia with a tracheostomy due to airway blockage. After just a year, her tumor had shrunk enough, even though it was just 25.8%, that she could be decannulated, and she continues on study with further tumor shrinkage without the need for a tracheostomy. So that is a clear success for this individual patient. I had shown you another patient when we didn't have an effective medicine, so I want to show you this patient here. I've known him for many, many years, since he's been 6 years old, and he participated in multiple clinical trials, 6 prior treatments before we started Salumetinib. He had a shrinkage, which was a partial response, but unfortunately developed asymptomatic decrease in left ventricular ejection fraction. We had to hold drug. I was really concerned, but the patient recovered his cardiac function. We started Salumetinib at a reduced dose and continues on treatment to date with further minimal decrease or stable tumor. These are the patients we really have to thank for. Without them, we would not have learned what we know today. And an important lesson for us from this patient was that we need continuous Salumetinib exposure for sustained responses. Earlier on, I mentioned that we used the natural history data as a control group for Salumetinib, and this data is shown here, where in blue you see patients enrolled on our NF1 natural history study, and in red, patients enrolled on the SPRINT trial. And you can clearly see that there is a clear difference in the natural history by the administration of Salumetinib. At 3-year follow-up, 84% of the patients on the Salumetinib arm were free of progression, and only 15% of the patients on the natural history arm. So I was very glad that we had continued enrollment and evaluations on this study. And here you see the difference in time to progression comparing the placebo arm of the tipifarnib study to patients who enrolled on our Salumetinib study with progressive neurofibromas, and here the comparison to the prior clinical trials. That is most certainly is an advance. It took 30 years from the identification of the NF1 gene by Drs. Collins and Ray White and others linking RAS to NF1, including Dr. Lowy, to having an FDA-approved agent. Since 2020, when Salumetinib was approved, it has been approved in many other countries, including Europe, Australia, Israel, Brazil, and Russia. And the NF1 team has worked hard on getting the data from our SPRINT trial to the different regulatory agencies in collaboration with AstraZeneca. It is really a marathon and not a sprint. And I come later in the talk to how we can hopefully accelerate this process. I also want to quickly mention that we have an adult study of Salumetinib, given the success that we saw in children. And this is done in collaboration with Drs. Alice Shen and Geraldine O'Sullivan from the Adult Developmental Therapeutics Clinic. This trial is nearly completed enrollment, and we have observed partial response rate similar to the children, improvement in pain intensity and pain interference. I'm very proud to say that the interventional radiology department has been fantastic in obtaining serial biopsies for us from these patients, which was never done before. We have shown target engagement with decrease in phospho-ERK as expected, and are conducting a series of additional analyses. Enrollment on this study is nearly complete, and an adult registration study is underway, and Dr. Geraldine O'Sullivan will serve as one of the PIs, as the US PI for this study. I will talk more about where we're taking plexiform neurofibromas later, but want to shift now to identification of MPNST precursor lesions. I already mentioned earlier that we were able to identify lesions that we call distinct nodular lesions. Our ability to do whole body MRI here at the NIH Clinical Center without charging anyone really has been a major advance. On the left panel, you see a patient with a typical very large truncal plexiform neurofibroma. And on the right panel, a patient with a very large plexiform neurofibroma and scoliosis, but also 3 distinct nodular lesions. After we identified them first, we really saw them in a number of additional patients within plexiform neurofibromas, outside of plexiform neurofibromas. When we looked at FDG PET scanning, we saw that these tumors are FDG PET avid in contrast to the surrounding plexiform neurofibroma. They were typically round and well demarcated, and they developed over time. Now, why are these lesions important? I'll show this on this next patient. This was a 15-year-old who came to the NIH, and the mother came and said, I come here because you are the expert in NF1 plexiform neurofibromas to enroll on the natural history study with a pelvic plexiform neurofibroma that had a distinct nodular lesion that was FDG avid. At that time, the biopsy showed a neurofibroma. The lesion persisted but didn't grow in volume. And when it had a PET scan avidity of 10.8, we did another biopsy and it was an atypical neurofibroma. Our pathologist said, don't worry, Brigitte, because these atypical neurofibromas, they don't metastasize. And that is very true. However, after we followed this patient for some time, within just 6 months, this tumor did not metastasize, but transform to a highly aggressive MPNST. The patient underwent surgery, had resection and radiation, but died in quite a bit of misery with intolerable pain. And many times I wondered, if I had known that this would happen, would we have embarked on a surgical procedure, even though it was in a difficult place? So this patient was, for me, certainly one of the patients that I'll never forget. Taking forward, we had other patients with a similar situation, and we knew we really had to study this more. The NCI and the Children's Tumor Foundation sponsored us to have a state of the science meeting to look how we could make progress in NF1, particularly in malignant peripheral nerve sheath tumors. And we identified that these patients who developed these nodular lesions, as you can see in a panel on the top again over time, many times have CDKN2A loss, a characteristic feature of these atypical neurofibromas. And when we looked at the growth characteristics in contrast to the left lower panel of dominant plexiform neurofibromas that do not grow in adults or very little, we saw that the distinct nodular lesions grow independent of age and have a faster growth rate, in particular in the older patients compared to the plexiform neurofibromas. Our pathologist, including Dr. Mia Tenen, who is our pathologist here at the NCI and has seen all of our patients, identified a lesion called ANUP at atypical neurofibromatous neoplasm of uncertain biologic potential, which have 2 or more of the criteria listed above, as tumors that may be at greater risk for malignant transformation. And having these pathologists here at the NCI was really an amazing meeting. We also identified the need to clinically more characterize these lesions, and Drs. Ligius and Farnet, both in the picture here up front, and Dr. Christine Hyam, who was a fellow in my branch, in my section, then went about and we studied the patients out of Belgium and out of England and at the NCI with atypical neurofibromas that were pathology confirmed. There were 63 patients with 76 atypical neurofibromas. The median age of diagnosis was 27 years. Most of the lesions were FDG avid, and pain was the most frequent presenting feature. However, 13 atypical neurofibromas, and that 17% had no signs or symptoms. And 21 of 63 patients had a history of an MPNST either prior to or after development of the atypical neurofibroma. The proportion of patients with the disease manifestations when they happen, the atypicals or the MPNST shown in the survival plot, and you see the median age for atypicals was 27 and for MPNST 51 years. This data allowed us to form the hypothesis that the MPNSTs do not develop as we previously thought in plexiform neurofibromas, but that likely many of them develop through the stage of an atypical neurofibroma, which is characterized by loss of CDKN2A, and then additional mutations occur which result in development of an MPNST. With this, we embarked on strategies how we could prevent an MPNST or potentially develop better treatments. And a very important treatment modality became marginal resection of atypical neurofibromas. Dr. Prashant Chittiboina, a neurosurgeon at NINDS, has been our key collaborator and has conducted surgeries on more than 40 patients at the NIH at this point in time, which have been safe and feasible. And we have a minimal, if any, recurrence rate in these patients with very marginal resection. So unlike aggressive MPNSTs where you need a wide resection, these tumors are really just shelved out. And Dr. Chittiboina had this nice hypothesis that we can do this, or he can do it without lack of development of morbidity, because this is one of the nodules that are in a nerve that then enlarge, and removing them really doesn't injure the entire nerve, and most of the patients have continued function that is similar to pre-surgery. I think we talked a lot about imaging and how we use imaging to detect malignant peripheral nerve sheath tumors or transformation. But Dr. Jack Shern, a tenure-track investigator in the Pediatric Oncology Branch, and Dr. Taylor Sundby looked at this from a different angle by saying, can we use blood samples to detect something that will tell us that a tumor has become malignant? And so they've developed a very nice assay of cell-free DNA for detection of MPNST. In addition, all of the tumor samples that we collect undergo genomic dissection, and many of them undergo single-cell sequencing to understand the malignant transformation better. With us characterizing atypical neurofibromas, we have also now embarked on clinical trials targeting atypical neurofibromas. And Dr. Andrea Gross is leading a phase 1/2 trial of a CDK4 inhibitor, abemaciclib, which is a very rational treatment for patients that have CDKN2A loss. The trial has the primary objective to look at tumor shrinkage, but Andrea incorporated biopsies and a number of comprehensive correlative studies to inform us more about these tumors. And then finally, over the past 2 years, 2 new mouse models of atypical neurofibromas have been described that actually recapitulate the transformation to malignant peripheral nerve sheath tumors, and we can now embark in collaboration with others on preclinical trials. This shows the nice work that was a collaborative effort between the NCI and Washington University with Angie Herby and Adal Chaudhuri, where they took healthy volunteer samples, plexiform neurofibroma blood samples, and MPNST samples, isolated the DNA and performed ultra-low passage whole genome sequencing, and then used the fragment lengths and copy number variations and alterations to distinguish tumor from non-tumor. And it's pretty impressive that plasma cell-free DNA was able to distinguish pre-treatment MPNST from plexiform neurofibroma with an accuracy of 86%. And very excitingly also that the cell-free DNA actually correlated with tumor size on imaging. And this, I think, may be something that we really can use into future clinical trials to assess response and resistance potentially earlier than what we can do with imaging studies, and also to monitor patients for development of malignant transformation. Obviously, this is something that will be applicable to other tumor predisposition syndromes as well. I'm showing you on the next slide very exciting data, and this is courtesy Jack Shern, a single-cell atlas of human NF1 tumors. So what you see here is single-cell sequencing data from 41 individuals with nerve tumors, where each dot represents an individual cell. There were 600,000 individual cells represented in this analysis. And this is from tumors at different stages. Down here, you see the Schwann cells from benign plexiform neurofibromas. In the orange, the tumors that are transitioning to become malignant. and higher up the tumors that have become aggressive malignant peripheral nerve sheath tumors. In this work, Dr. Schern and colleagues are able to catalog the cellular heterogeneity that is present in these tumors. And having a detailed transcriptomic map of these cellular populations, we really hope over the course of time will help us understand the cell populations and be a strategy to develop better treatments for these tumors. I want to thank Jack and Juan Zhang who have done this work. I want to thank Rosie Kaplan who's provided her expertise to this, and also every patient is enrolled on her omics protocol. And I want to thank Mickey who went multiple trips to the OR to help us get these tumors in the fashion that they are needed. It is really teamwork to get to this. On the next slide, I want to show quickly another patient example also provided by Jack Schern, one of our patients, an 11-year-old female with NF1 who had clearly one of the risk factors on NF1 and whole gene deletion. She developed an MPNST while on treatment with selumetinib and had surgery at the NIH Clinical Center. So you see the single cell atlas for her primary tumor, and then also for her metastatic lesion. And Dr. Schern highlights that we can now look at the differences in tumor cells and lymphoid cells and other cells in the tumors that will inform us and provide more detail on the biology of these tumors. We talked about the natural history study and when do we stop a natural history study. And I'm here to say that we will be closing our old natural history study, but only to be opening a new natural history study that will have a very dedicated focus on studying patients that are increased risk for MPNST. Our primary goal will be to characterize the number of atypical lesions and malignant lesions that we can identify using a surveillance and management algorithm that we have worked on for quite some time. Patients with NF1 and at least one of the risk factors identified here will be eligible, undergo standardized clinical evaluation, whole body MRI with diffusion weighted imaging, FDG PET, and clinical MRI with contrast as indicated. In addition, we will follow these patients serially for cell-free DNA, cytokines, and other biomarkers. A multidisciplinary team will review risk factors using a checklist and will determine the management using our algorithm, which would be then follow-up imaging, biopsy, or resection. I'm very excited about this study. It's a huge collaborative effort. And I do want to thank at this time Thea Steinberg, who provided statistical guidance, but not only for this study, but for all of our NF1 and many of our solid tumor trials. So Thea, thank you very much for always being there for us. In the following, I would like to quickly highlight an important aspect of our work, which is intramural, extramural collaborations, and how these even more enhance where we get to in NF1 and how the NIH Clinical Center really is an important aspect of this. The first is mouse models. I have no mouse models here at the NIH for NF1 Flexophone Neurofibromas, but both the Ratner lab in Cincinnati and the Clapp lab in Indiana developed preclinical transgenic mouse models of NF1. And really excitingly, Dr. Ratner's model first demonstrated that the MEK inhibitor selumetinib was the first agent to work in her mouse model of neurofibromas. Dr. Clapp subsequently demonstrated the same. And then more recently, Dr. Clapp actually demonstrated that another agent also works not only in the mouse, but in people. So I would say we can say this is a validated mouse model, which is something we don't have frequently in cancers. And obviously all of our clinical trials moving forward will go through one of those mouse models. But Dr. Clapp identified in his preclinical model that cabozantinib, a multi-targeted receptor tyrosine kinase inhibitor, actually shrinks tumors. The NF Clinical Trials Consortium, which is Department of Defense funded, then conducted a clinical trial of cabozantinib for patients with NF1 Flexophone Neurofibromas due to concern of toxicity, because cabozantinib can cause a number of toxicities. They limited this to patients 16 years and older, but you can see that a number of patients responded. The response rate was 42%. I think very excitedly, this did show again that the preclinical models can predict for response. The NF Clinical Trials Consortium has become very important to conducting clinical trials at multiple sites. And this study that I'm presenting you here is a very important effort, I believe. And this will be led by Dr. Andrea Gross. It will be a salumetinib secondary prevention trial. I showed you that salumetinib can shrink tumors, but it doesn't make them go away. And so we were thinking, could we use salumetinib to actually prevent the development of morbidity? Imagine this young kid here, if we could treat her at age of 11 months or 17 months, as opposed to at age of 3 years when she has a disfiguring tumor. So this is going to be the question that Dr. Gross will address, and be very glad that we have the NFCTC to collaborate, because we won't be able to treat these very young patients at the NIH Clinical Center. So in part 1 of the study, we'll answer a very important question. What is the incidence of asymptomatic Flexophone Neurofibromas by using whole body MRI? The second question will be, once we identify asymptomatic Flexophone Neurofibromas in high-risk locations and treat with a MEK inhibitor or not treat and observe, will we actually show that we prevent the development of morbidity? And the third part will be in patients who respond to MEK inhibition on continuous dosing. Can we switch the patients to an intermittent dosing schedule, which hopefully will have less toxicity and sustain activity? Dr. Gross was awarded a DoD Clinical Trial Award for this, and AstraZeneca is providing funding for the whole body MRIs. This study should open soon, and I'm really excited about it. Another collaborative effort I want to mention is the Developmental and Hyperactive RAS tumor spore. It is spearheaded by Dr. Wade Clapp from Indiana University and Dr. Kevin Shannon from UCSF, and has 3 primary projects. One of them is NF1 plexiform neurofibromas and transformation to MPNST, and this is where I am part of. They have another very important project on NF1 associated glioblastoma, and a third one on JMML, leukemia that occurs more frequently in NF1. In collaboration with the Spore, they have analyzed blood progenitor, cytokines, the tumor kinome, and do DNA and RNA sequencing on our tumors. They also do correlates for Andreas abemaciclib study and evaluate preclinical agents for clinical trials, a trial that will very soon be starting, and I'm very curious to see what the outcome will be a phase 1/2 trial combining salumetinib and cabozantinib for patients with NF1 plexiform neurofibromas. For the last part of the talk, I want to quickly focus on the MPNSTs. We need ability to coordinate clinical trials for these rare tumors, and the Sarcoma Alliance for Research and Collaboration has conducted clinical trials with us, collaborating with them for a number of years. Denise Reinke was the chief of SARC, and I'm very, very thankful for her for support over many years. I have to say, of the clinical trials that other investigators and Dr. Kim and I conducted, unfortunately, we have not seen partial responses, and the median progression-free survival has typically been around 2 months. It's very sobering, and we need to do a lot better for these tumors. We're currently conducting a clinical trial combining the MEK inhibitor salumetinib with an mTOR inhibitor based on preclinical studies that Karen Schikowsky performed in Boston in her transgenic mouse model, where she saw tumor shrinkage for the first time in these patients. We are participating in this trial here at the NIH Clinical Center and using FDG PET as a readout, as a pharmacodynamic readout. I have to say we are proceeding to the second stage and enrolling on the second stage, which means that a minimal amount of activity has been seen, so we could move to the second stage. And another clinical trial that we are developing currently in collaboration is a trial that demonstrated very substantial tumor shrinkage in Dr. Schikowsky's model. It is a combination of a MEK inhibitor, a bromodomain inhibitor, and a checkpoint inhibitor. And I'm very much hoping that this will translate in more clinical activity than we have seen in MPNST to date. We have been living with virtual meetings, and I want to just highlight how important in-person meetings are, and also how much the NF community has grown, going from the first NF International Consortium for the Molecular Biology of NF1 and NF2 in 2000, and in beautiful Aspen, Colorado, where we had 150 attendees, to the last non-virtual meeting in San Francisco, where we had more than 500 attendees. I can just attest to how much interactions and in-person interactions help us advance science, and also being in beautiful locations where we can think about things differently. It took so long to make progress in NF1 that I'm thinking, how can we make progress faster? The last 2 or 3 slides, I just want to briefly mention 2 efforts that I'm very excited about. The FDA recently provided guidance for natural history studies, and both of these new efforts have taken this guidance seriously. The first effort is one that will focus on making progress in children that have tumors that have either RAS mutations or RAS pathway alterations, or in patients that have rhizopathies such as NF1, where there's a germline mutation that results in RAS pathway activation. The fact that we've been able to treat patients with NF1 with success led to this development of this effort, which has a preclinical component, a natural history study that is open now, and we plan to bring our first patients to the NIH Clinical Center, and a public health genomics approach. I'm also excited about this because it is a wonderful collaboration with extramural advocacy, intramural DCEG, and CCR, and the RAS initiative. And I'm sure you'll hear a lot more about this soon. And then, of course, I want to briefly mention our Moonshot-funded My Pediatric and Adult Rare Tumors Network, where we focus on developing a natural history study to study children, teens, and young adults with rare solid tumors. This natural history protocol is open for enrollment. Dr. Heidira Del Rivero was the first PI, and now Dr. Mary Frances Wedekind is the PI. It was a huge effort, but we have a very nice pipeline to comprehensively evaluate these patients, to provide guidance to these patients for treatment, and to learn about the tumors. Very importantly, also, we can enroll patients remotely during the COVID pandemic, which has made it feasible for patients to learn more about their tumors, even though they could not come to the NIH Clinical Center. Advocacy Partnership has been hugely important for this, and Dr. Abby Sandler has led this effort, and I will show you why that is important in a moment. This shows you the number of patients that have been enrolled since the start in 2019. It's quite impressive, and it's really from many different states in the United States and countries around the world. I'm highlighting 2 tumors, adrenocortical carcinoma and chordoma, because I have learned that it is true, we need champions for tumors to make progress. Somebody has to say, this is my tumor, and this is what I focus on. And Dr. Del Rivero is focusing on adrenocortical carcinoma and has established a very rich collaboration at the NIH and outside of the NIH to make advances in these tumors, including establishment of models, single-cell sequencing, and development of clinical trials. And Dr. Mary Frances Wedekind and Dr. Lini John have taken on chordoma. We have about 300 to 500 adults with chordoma per year, but only 30 patients with pediatric chordoma. But through really working through this and collaborating with advocacy, we had a first NIH pediatric chordoma clinic, and now Dr. Wedekind and Dr. Akshantala will be leading very exciting clinical trial with 2 immune checkpoint inhibitors for these patients. So I'm hoping by identifying more champions and having our approaches such as the Rhizopathy Project and the natural history study of rare solid tumors, that our progress will go more quickly. I want to thank first and foremost our patients and families. I hope I have shown you how much they go with us and participate and are willing to go through clinical trials. I want to thank the NIH Clinical Center, and NCI. This is a fantastic facility to conduct research. Our collaborators, the funding agencies, industry partners, our NF1 team for the huge amount of work that went into getting selumetinib approved. And then all the nurses, research nurses, physician assistants, nurse practitioners, data managers, patient care coordinators, social workers, postbacs, and psychologists. It is really a team effort. Thank you so much.
Dr. Widemann, thank you very much for the presentation. We have a few minutes, and I need to remind the audience that they can submit questions still. We have a few minutes to go. If you the button below the videocast screen, you can use that to submit the questions. I'm also supposed to remind people that the CME code for this presentation is 37924. If you text that to Johns Hopkins, make sure you get credit. You mentioned, the only time you mentioned NF2 was in a nice meeting that looked like was in Aspen. And there's no, and I know that I think it's not as common as NF1, but are the things that you learned in NF1 not applicable to?
They are.
They are?
Yes, they are. I have a big echo. I don't know what that is, but you know, it's actually really great that you mentioned this. NF2 is much less common. It's like about 1 in 30,000 people. There's a huge unmet need, and Dr. Chidi Boyna, our neurosurgeon, actually has a natural history study for these tumors. There is activity of bevacizumab, an anti-angiogenic agent, in patients with vestibular schwannomas. But to date, there is no effective medical treatment. The NF Clinical Trials Consortium studies these tumors, and I'm very interested in opening a clinical trial with a multi-targeted kinase inhibitor that is open in the NF Clinical Trials Consortium. I'm a little bit stretched right now because we would need, I think, more research nurse support to actually do this, but it is a very much unmet need, and I'm very grateful that Dr. Chidi Boyna has taken on studying these tumors here, and I'm hopeful that we can develop clinical trials here for these devastating tumors as well.
One of the questions that we do have from another member of the audience is, since these tumors often start early in life, is there a demonstrable impact of the hormonal changes associated with puberty on the rate of tumor growth progression, or is that a factor at all?
We did study this because patients actually would ask us this question all the time. We have not seen that plexiform neurofibromas accelerate their growth during puberty. We're pretty confident about that. But we have at least anecdotal data that cutaneous neurofibromas can evolve very rapidly during pregnancy, but for plexiform neurofibromas, we have not seen it.
Okay. What are the, if you were to summarize the lessons that in this incredible 30 years that you've spent in this field, that the most important lessons that are applicable to the study of childhood malignancies, the things that perhaps surprise you the most, or the things that any new investigator to the field, you would say that you don't have to go through this to learn X, Y, or Z, because I'm going to tell you now after 30 years of experience.
Yeah, I think one of the lessons is to really look more than assume. I had a lot of assumptions, and a number of them were proven wrong. And I thought I knew that these tumors don't stop growing, and I now know they stop growing. I think if we pay more attention to the patient and, in a sense, listen and observe the patient, and truthfully having less assumption and letting the data tell us, I think that being less biased about the thoughts that you have about things be a good advice. And then finally, I do think taking a risk. I'm a little bit an incrementalist. I go step by step, but if you take a risk, patients are willing to take a risk. And patients told me The phase 1 patients in oncology would tell me, I want to see these two drugs combined. And I told them, no, we can't do this because we first have to learn that it's safe, knowing that it was likely not going to work. So really thinking more from a perspective, what does the patient want and can we make it happen, and not necessarily go by the rules that we have established. I think that might be another advice.
Dr. Widemann, I want to thank you again for your wonderful talk. As the CEO of the Clinical Center, I want to tell you how proud we are to have sponsored this presentation. And you know, a year or so ago, I also watched you during the remembrance ceremony where we acknowledged the contributions of our pediatric patients who have died in a fashion that enabled us to learn more about the disease. And it's nice. It was nice to see your reactions then and how much you cared about the patients who were involved in this work. And it's very nice to see the kind of results that work has produced. And so congratulations as the Astute Clinician for 2021 at the Clinical Center. Thank you to the audience for dialing in, and everybody have a great Wednesday afternoon. Thank you.
Thank you so much.